Good afternoon, September 9, 2025. Our patient is here from Georgia, and he is here because he has back pain. He has two painful discs. We said L3-4, L4-5, correct? Left is 3-4-4-5, right is just 4-5. I'm going to do some num-num, little stick and burn. Everything's okay, just giving you some numbing medicine. You're doing fine. During the surgery, you can ask questions. We're doing a live stream. You're fine. It's numbing medicine. That's all. I apologize. And while I'm operating, I'll answer your questions. I'll talk to you and try to teach you. But to get started, while we're placing our needles, which is the first step of the surgery, Henry, why don't we share with the audience the 30 different causes of back pain. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. All right, welcome back. We've just gained access to the two discs we're going to fix on the left side, which is L3-4, L4-5. And we did our discogram. Now, it was not an evocative discogram, so I didn't ask the patient, if they're having pain. We kept the patient asleep. He was already asleep. We just kept him asleep. We did the chromodiscogram, thank you. The chromodiscogram means that we use the dye and we get to see the tear, the internal architecture of the disc. Architecture. We all know what architecture means. So we got to see the tear. You can see the tear there in the back of the disc. Thank you, Jordan. Shot. That black tear right there. Thank you. And we see that it's disrupted. It's not normal. It's torn. So there's definitely a tear in the back of the L4-5 disc, and it's big. And that's where his pain is coming from. He's got discogenic back pain. He also has sacroiliac joint pain and facet pain. So he's got 1, 2, 3, 4, 5 sources of pain out of the 30 that you just saw on your video. So there are 30 potential causes. He has 5 out of 30. Shot. Thank you. We are now inside the tear. Jordan, show us that. You guys see the tube on the lateral view coming in? Yes, show us the tube coming in from the back. There it is. That's the tube coming in, and then it enters the tear right where the herniation is. We're going to go in and zap away the herniation, clean up the tear so that it'll heal, and the patient won't have any more pain. Now, he's from Georgia. He traveled here, like our last patient. She traveled from the other side of Florida. The patient before came from Ohio. Sorry, Utah. I apologize, Utah. Our next patient is from Michigan. Yeah, Michigan. And our last patient is from Canada. So we have representations from the United States, from Michigan, Florida, Utah, Georgia, and our last patient is Canadian, all the way from Ottawa. How are we doing, guys? Good? Henry, any questions?
At this moment, no current questions.
My God, the audience knows everything.
Everything.
So this patient suffered with lower back pain for 4 years. Sorry, 40. 40. Let me correct myself. 40 years. And he worked as a cleaner. Anybody know what a cleaner is? Right, the cleaner. I'm just kidding. He didn't work as a cleaner. We were joking because it's the first thing that came to mind since my team did not tell me what his prior occupation was, but he's here with his lovely wife. And he, like many of you, has been watching our videos and decided to pull the trigger and come down here to Florida to get his back fixed. Because there is nobody in Georgia that does what we do. There's nobody that cures back pain. Any questions?
At this moment, no current questions.
All right, so either I'll digress into talking about movies from the 80s and 90s, or we can run a video showing how is it that these disc injuries can be so painful.
Start with that, and then
I agree.
And we'll go from there.
We'll go from there.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see from our video that back pain that comes from a disc injury, it actually comes from the back of the disc called the posterior annular tear. And it turns out that the posterior annulus is the only pain-sensitive structure in a disc that carries localized pain up to your brain, to the primary somatosensory cortex, Brodmann area 312, which is somatotopically organized so that your consciousness is fully aware of where the pain's coming from. Now, subcortical areas, such as the brainstem, also receive subconscious pain. We call those visceral afferent type pain fibers that travel to the subcortical areas of the brain that are not localized. But if you want localized pain, you want to know exactly where it's coming from, it's got to go to area 312, which is in the parietal lobe, just behind the central sulcus. And that's exactly what happens with the nerve endings from the sinovertebral nerve innervating the back of the disc. Now, if we were working on the side of the disc, you wouldn't have any pain that you appreciate through consciousness. It would be subconscious pain, and that's not sharp pain. That's dull, barely noticeable kind of pain that your brain basically ignores. But the pain that your brain pays attention to is called pain that goes to the primary somatosensory cortex, right? You all know what I'm talking about. We all have pain in our bodies that we're not really paying attention to. Think about your shirt. You put your shirt on in the morning, maybe you feel it go on, and then immediately you're not paying attention to it. You don't feel the shirt on your back anymore, do you, after the first minute? It's gone. The sensation of the shirt is gone. Even though the shirt's still there, you don't feel it, you're not aware of it, it's not in your consciousness. And that's because our brains are really good at suppressing stimuli, whether it's visual stimuli, whether it's olfactory stimuli, which is smell, whether it's gustatory stimuli, which is taste, whether it's tactile stimuli, which is touch, olfactory, we talked about smell, so, or auditory, okay? So we have all these different senses that are sensations our brain is able to sense, right? And we just basically ignore most of those senses most of the time. However, there are certain things that our brain cannot ignore, and that is pain coming to area 312 through somatic afferents. I'm getting wet again. What is wrong with our system today? So since it's my right hand, I'd have the blue towel on the right side. Make sure it goes to the bag. I would not have it that way. I would have it long way. So you make sure it goes in the bag. Okay, and then have a hook around so that it gets there. All right, any questions from our audience?
We kind of do. It's coming from Karsten on YouTube.
Hi, Karsten.
I believe he's
Welcome.
trying to finish his question, but the first of it is it when facet joints overstretch in REG, to their something? He didn't finish from there. So once he finishes his question, I'll let him know.
Is that Carson related to our anesthesiologist?
I don't think so. It's spelled with a C. So, we just got another question coming from B. Bala on YouTube
Okay.
saying,
Welcome.
Dr. Duke, I already saw you for my initial consultation, and I'm waiting for my insurance to approve the operation to do the piriformis muscle release on both sides. I also have lumbosacral spondylosis.
All right. Well, I hope we can help you, my friend. You may be waiting an eternity for your insurance to approve your surgery. I don't know what insurance you have, but good luck with that. Hopefully they will approve it. And we can get you all fixed up. By the way, our first patient we did this morning, she's already gone. Our second patient is still recovering. She was the cervical. We did 2 procedures, facet and disc. And she's just having some post-operative pain, very typical after having facet treatments, but she'll do fine. She'll be out of here soon. Any questions from our audience?
Yes. We got a question from Karsten. The full question is it when our facet joints move beyond their capacity or ability that we impinge the disc and thereby create injury?
Great question, Carson. So the way injuries occur to facet joints is facet joints have a capsule, which is a very strong connective tissue membrane that is around the actual joint, surrounds it, and holds the joint together, okay? And when you have trauma to that motion segment, what happens is your bone above goes to the right, your bone below goes to the left, or vice versa, and you rip everything in between the bones. You rip. You literally rip it apart. So you're going to rip what's between the bones. What's between the bones is the disc and the facet capsule. So you're going to rip the disc, and there's nothing to the disc except for the annulus. The center is jelly. The center is not going to hold anything together. So it's the annulus, or connective tissue, surrounding the disc, which is the connective tissue ring called the annulus fibrosus. That rips. That's how you get an annular tear. And then your facet capsule rips. That's how you get a facet capsule tear. When the facet capsule rips and tears, it never heals because you're always moving around. You don't give it time to heal. It would need about, 3 months for itself to heal without you moving at all, without you getting out of bed, which is not possible. Human beings don't lay in bed for 3 months and not move at all. And I don't mean laying in bed, moving around. I mean not moving in bed for 3 months. Think about like the movie Aliens, right? Stasis. Remember when they were in stasis and not moving at all? That's what you have to do. There is no human that can lay still. Therefore, your joint will never heal. The capsule will never mend. You will continuously rip it. You will get inflammation, scar tissue in the capsule, pain fibers growing in, and that is exactly what causes facet pain. Okay? Very simple. Don't ever ask me that again. Just kidding. I got Nikki to laugh.
We have another question.
We'll show you guys facet pain on the next surgery. Yeah.
Coming from B. Bala once more on YouTube asking as well, so would you operate and do the piriformis release and also the lumbosacral spondylosis at the same time?
My friend, you're asking a very good question. Are you asking, can I fix your disc and your piriformis at the same time? The answer is yes, I can. Do you need that done? I don't know. I don't remember your MRI review. So if I told you you need the disc fixed and the piriformis fixed, both, then yes, we can do them both at the same time. Just reach out to the scheduler and they will tell you how we can schedule fixing whatever needs to be fixed. But I don't remember distinctly what I recommended for you. I don't remember if it was one thing or both things. But yes, typically we can fix the disc and the piriformis, the SIs, the facets, all in the same surgery. So, all right, and if it's been more than 6 months, you should probably schedule another visit with me on Zoom. Just contact our MRI review, Natalie, and she will set you up for another Zoom. Okay? Great question. All right, we're moving into the second disc, which is the L3-4 on the left side. Remember, we're fixing 2 discs on the left, 1 on the right. L3-4, L4-5 on the left, and just L4-5 on the right. Why is that? Because when I do my MRI reviews, I actually look at the MRI myself, and I want to figure out which side I need to go in to fix. So I look at which side has the tear, which side has the herniation, which side is the nerves getting pinched. This guy has had pain for 40 years coming from his discs, and because he's lived with back pain for 40 years, it changed the way he walks. He also had a pinched nerve on the right side, causing a foot drop. Foot drop. Sorry, right? I meant left. This is broken.
Nikki.
Another grabber. That's about $1,200. Let me have this, please. Another grabber, please. Were you able to fix the last one? No. Once they're gone, they're gone. Oh my gosh. So, our German-made tool has broken, but we got a lot of years of good use out of it, right, Louise? A lot of years. But, you know, unfortunately, people wonder why is spine surgery so expensive. I'll tell you what, if you could make all the equipment cheap and you can make my employees work for $10 an hour, then it doesn't have to be expensive. Just get everybody to volunteer, all 50 employees, including the doctors that work here, get my supplies at communist Russia prices, aka free, and then our surgeries will be dirt cheap. Oh yeah, and get the landlord to stop charging me $1 million a year in rent. And the electric company to write off that $12,000 a month in electric bills, right? Oh, and the list goes on and on. Most people don't understand how expensive running a mini hospital or a surgery center is. But they just see the price and they think it's too much, but they don't understand how expensive it is to run a healthcare facility. A lot of the money is truly wasted, unnecessary. Look at the size of that herniation. We've been taking out some giant herniation. I literally pulled out 3 or 4 that size. Bring the other ones. I'm going to show them to you. They just keep coming. This poor man. And look how ugly they are, by the way. Just look at those. Look at that. Look at that. Look at those, guys, gals. Look how dark, and you know why they're dark? Hemorrhage. Inflammation and hemorrhage into the inflammation. That hemorrhage turns dark. It's called hemosiderin. Incredible, huh? Lots and lots of pieces. All right, any questions?
Yes, we have a good amount of questions coming up. This next one from B. Bala once more on YouTube.
Yes.
Asking, can you please explain what is exactly lumbosacral spondylosis? Thank you.
Sure. So what is lumbosacral spondylosis? Well, lumbosacral just means that part of the spine, the lumbar sacral region, which is lumbar and sacral, which is L1-2, L2-3, L3-4, L4-5, and the actual lumbosacral junction, which is L5-S1. So that bottom disc, the L5-S1, is the lumbosacral junction, or the farthest disc down in the body. And spondylosis is basically, there's another big herniation. Spondylosis is degenerative disc disease. So it's the same thing as degenerative disc disease. Well, what does that mean? It means that the height of the disc is collapsing, so top down. It's shrinking from top down. And you get changes in the bone, the end plates above and below the disc, the superior and inferior end plate. You get what are called modic changes in the end plates, which is edema, pitting, irregularity. This is all due to arthritis of the disc, or degeneration and arthritis, inflammation happening inside the disc that affect the bones on either side of the disc, above and below, called the end plates. So you get these arthritic changes with scraggly, irregular surfaces of the end plate. You get a loss of cartilage. You get a collapsing of the disc height down. And you get a degeneration of the disc itself, the nucleus. See this nucleus in here? Look how ugly it is. Look at all that inflammatory tissue. See the pink stuff? The irregularity of the end plate right there? All that is spondylosis. That's what spondylosis is. It's basically arthritic structural changes. God damn it, give me that grabber. In the disc that come from degenerative disc disease. Okay? Truly unimportant. 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 That's like, I have to climb this mountain to get to the other side. And why is the ground brown or yellow or irregular or more pebbles? It doesn't matter. In the end, you got to get to the other side. Those details are not important. They don't change anything. What matters is the height, the distance, altitude, how much oxygen there is, whether there are wild animals that will attack you along the way, whether it's cold, how cold. You need to think about exposure protection, but don't think about the color of the rocks on the mountain. That's what spondylosis is. It's absolutely meaningless. Nonsense, unimportant garbage that lots of doctors point out and show you so that they can convince you to have fusion surgery done. Look at all this stuff. This is all severely degenerated disc. This is part of spondylosis. Not important, but must be cleaned out of the tear in order for this disc to heal properly. So I'm going to clean it out.
We have another question.
Sure. Have we done how a disc injury causes back pain?
We have done that, but we haven't shown what how to cure discogenic
Why don't we
lower back.
do how to cure, how we use the Duke laser disc repair
Of course.
to cure discogenic back pain. And then we'll take some more questions.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear, causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. We're pulling out pieces of herniation and repairing this disc. You could see from our video how we use the laser to repair the disc. The laser is a very powerful tool, very precise. The most precise tool in medicine is the laser. It's the safest tool in medicine if you know how to use it. In the United States, our lasers must be FDA approved. Ours are. And our laser fibers are FDA approved. So everything is FDA approved for us to use it. Everything about this surgery you're seeing is FDA approved. Right, Luis? All right. Any other questions?
Yes. This next question is coming from Mike on YouTube, asking, Dr. Duke, does this man have narrowing of cauda equina with such an old herniation and repetitive herniations? Thank you for your knowledge.
Thank you. Does he have spinal narrowing or spinal stenosis? The answer is yes, he does. But unfortunately, most people think of spinal stenosis as being really obvious on the MRI, and they look for what's called central stenosis, which is narrowing of the center of the spinal canal, which is very easy to see. It's very obvious. But most patients don't have central narrowing. They have narrowing of the lateral recess and the neural foramen, which are way off to the side. And 99% of doctors have no clue how to find it. It's to the side pictures. It's not on the center picture. So patients can't find it, doctors can't find it, but 99% of symptomatic spinal stenosis comes from lateral recess stenosis and foraminal stenosis, not central stenosis, not extraforaminal stenosis. So there are 4 zones of narrowing. Central, which is the middle, easy to see. It's what everybody looks for and they can't find most of the time. Lateral recess, neuroforamen, extraforamen, which is outside the foramen. 99% of symptomatic spinal stenosis or narrowing occurs in the lateral recess or the neuroforamen. And that's why 99% of doctors miss the diagnosis, because they have no clue what the lateral recess is. They don't even know what it is. And they don't know what the foramen is. So they're not looking in the right place. That will change, obviously, in time. As I teach more of you, you'll go out and teach your doctors where to look for the answers. Great question. Next.
Next is a comment, I believe, coming from Karsten once more on YouTube,
Karsten.
asking or saying, keeping facet joints aligned seem to keep disc correctly aligned too. Animals steer by using facet joints for forwardness and steering after their senses, included our lost sense, which is common sense.
Ha! I love that. Good job. Is it Karsten or Carson?
Karsten with a T.
Good observation, Karsten. I like your thinking. I like how you see things. You are correct. Facet joints are important for alignment. You're right. They set the alignment of the spine. When they're damaged and out of alignment, your spine gets out of alignment. We're pretty much done with this disc. I'm going to grab a few more chunks. We're going to go to the other side. There's been a question from our operating room for Karsten. What nationality are you? Where are you from?
Once he answers that, I will let you know.
Any other questions in the meantime?
No current questions, so we do have a comment coming from B. Bala once more on YouTube.
Give me 1 second.
Not a worry.
His drop foot was left, correct?
Left and right.
Left. But he wore the AFO on his left. And he's had surgery on his disc before? I can't remember. Did somebody... he had the disc seal. Wait, are we live?
Yeah, we're live.
Oh, good. I mean, people can hear me.
Yeah, we can hear you.
All right, folks. This patient had the disc seal. An absolutely garbage procedure. Everybody asked me about. Here's an example of somebody who had the disc seal, and of course, it did not work. If anything, it made it worse. You want to know why that disc looks so bad on the inside? Remember how garbagey the disc was? I told you guys he had hemorrhage. That was the disc seal. Junk that was injected into his disc. That's why his disc looks so bad. Did not work, obviously. He's here having surgery. Do not waste your money and time on disc seal. You saw what it did to the nucleus. Henry?
Yes, sir.
I want you to take a picture in a moment. You're going to use this for website for disc seal. Okay? This is
Copy.
what your disc will look like after disc seal. Okay? You understand what I'm saying?
Yes, I do.
How many people in the world have ever seen the inside of a disc after disc seal? Like literally us, that's it. Why? Because we have an endoscope. We can see inside the disc. And how many people do endoscopic inside the disc surgery? Very few. You understand? Let's see if I can grab that big chunk of herniation out of there. God. Folks, this is a disc seal disc. Very important. I've taken disc seal questions. So many patients ask me, why don't you do the disc seal? What do you think about the disc seal? Does the disc seal work? No, it doesn't work. It never works. Okay? Not in my experience. Of course, I'm going to have the disc seal companies suing me, but so what? I'm allowed to say the truth. In my experience with my patients, I've never seen the disc seal work. Here's another patient that had the disc seal and it did not work. Now you're going to get me some of those discs, Luis, and we're going to take a picture. Henry's going to put it on the website. Lights on. Come on. Little antibiotics. Questions?
No current questions, so we do have a comment coming from B. Bala once more on YouTube. Following up on their question about...
Bring me the ugly discs.
Following up on their...
Actually, I guess we'll do it afterwards.
...question with lumbosacral spondylosis, saying, yes, I see that. Thank you for the explanation. When I go back, I want to sit down with you so you can explain exactly what I have that needs to be addressed. Thank you, Dr. Duke.
Yeah, you're welcome. That's the best thing to do. If you want to know what needs to be treated, do your MRI review with me. It's free, unless you've already had one, in which case you may have to pay for a second one. I got it. We do one free MRI review for everybody. Where's the rest of it?
I think I sent it over.
No, come on. Don't tell me that. Guys, look at this. Okay, we're going to get some more. Okay, we're going to get some more. Pickups. Don't worry about it. Don't worry about it. All right, we're going to get some more of this, but look how nasty And this should not be black, all right? Look at this disgustingness here. This is from the disc seal. Look at that stuff. That's gross. How many of you ever seen this kind of disgusting nuclear material after my surgery? It doesn't happen unless the patient's had disc seal. Look at that stuff. It's garbage. I'm going to get some more for you from the other side. Here you go. All right. Now we're going to go to the other side. I'm going to come over there. If you have questions, feel free to ask.
We do have a comment coming from Karsten on YouTube
Sure.
saying, I am from Denmark.
Denmark.
History will say, quote, the Dane who revolved humanity to reorganize use of facet joints to return to nature, where facet joints are primary weight distributing joints in uprightness.
Well, my friend, the facet joints accommodate 18% of the weight, typically on average. Sorry, 15%. 15 to 20%. Depends on what part of the spine you're in and the patient's posture. But the facet joint is not the primary bearer of weight in the spine. The disc is. The disc bears 85% of the weight of the body in an upright position. The facets bear 15% on average. Okay, that's in a normal situation. So maybe you're telling me you envision an animal where the facets bear 50%, 51% or more, the major weight. I'm not sure what position you would have to be in for that. But if you look at the size of the disc and you look at the size of the facets, you can easily see the disc is much larger surface area than the facet. And I think evolutionarily humans have evolved with the disc being the primary bearer of weight. And so I think it's natural that the disc bears the weight. The disc is designed to bear the weight. As a matter of fact, I don't think disc injuries were common among humans prior to the Industrial Revolution. I think the development of high-speed travel and vehicular travel like cars, bicycles, motorcycles, has led to, and of course multi-story buildings, has led to people falling or getting into accidents that cause trauma to the disc. But prior to, 150, 200 years ago, I don't think humans had many disc injuries. I think disc injuries were uncommon. But now with our lifestyle, we didn't have gym set. Yeah, well, people don't tear their discs in the gym. They make the herniation worse being in the gym, but the original tear in the disc, the original injury to the annulus and the facet occurs with greater force than you can apply in a gym accident. It's a motor vehicle accident or a fall, something like that. All right, here we are again on the other side at L4-5. So we already fixed the opposite side, left, L4-5, L3-4. Now we're going to fix the right, L4-5. And this will be the last disc that I fix in this particular patient from Georgia. He traveled all the way from Georgia. They drove 8 hours to get here. He and his wife, and they were heading back home on Friday to Georgia. Hopefully in a much better state than he is before surgery. All right, let's show the audience a video comparing what we're doing here with the laser versus other types of invasive treatment that don't work for back pain. Hi, I'm Dr. Duke Machen. We've just completed our free MRI review with Duke Spine Institute, and I've diagnosed you with discogenic back pain. The spine is made up of many bones and joints. It's the joints that are actually the source of back pain. The disc is by far the most common source of back pain, as is in your case. It is the cause of your back pain, the primary cause. In your case, the primary cause of your back pain is an injury to the disc in your lower back that is causing inflammation and hence back pain from the inflammation. Inflammation is the source of all pain in the body, whether it's a broken bone, whether it's an injured joint, or an arthritic knee. Pain comes from inflammation. Inflammation is a process where your body is trying to repair a damaged joint, and it creates swelling, tenderness, heat, and pain. The pain you're experiencing in your lower back is primarily coming from a small tear located within the back of the wall of a disc. Now, I may have diagnosed you with more than one disc as the source of your pain, and each of those discs cause pain through the same mechanism. As you see in our video, trauma causes a tear in the back wall of the disc called a posterior annular tear. At the same time, it fragments the nuclear material just inside the wall, and over time, after the injury, you, through activities, push out small fragments of disc herniation into the tear, which then causes cycles of inflammation and pain. And that's why you're experiencing your lower back pain. At some point, your back pain could become permanent and not just reside in your back and not ever leave. But typically, people go through a phase where the back pain is cyclical, where it comes and goes, and activities are generally the cause of the back pain flare-ups. In your case, we can fix your back pain by performing a state-of-the-art procedure only available here at Duke Spine Institute. This is a minimally invasive arthroscopic procedure performed with a laser. This procedure is called the Duke Laser Disc Repair. We've been performing the Duke Laser Disc Repair since 2006 here at the Duke Spine Institute. To date, we've had 0 complications. The Duke Laser Disc Repair is the safest, most effective treatment for back pain coming from an injured disc like yours. We're recommending you consider the Duke Laser Disc Repair as your primary and main treatment option to get rid of your back pain quickly and permanently with minimal impact on your life. Recovery from Duke Laser Disc Repair is just 1 hour. You're going to go back to your hotel after the surgery. You'll spend the night in your hotel recovering, and then in the morning you'll come in for a quick checkup. The checkup usually takes about 30 minutes, and then you can go back home after the checkup. Alternative treatments to the Duke Laser Disc Repair are far more invasive, and the outcome of those treatments is far more uncertain. There are many surgeons offering treatments such as laminectomy, discectomy, spinal fusion, disc replacement. Other treatments include injecting materials into your spine, such as epidural steroid injection, or injecting material into the disc itself that will supposedly repair the disc. I can tell you, we used to perform these treatments and they don't work. They either don't work or they don't last. And if they do work, they work temporarily, and they're associated with a high complication rate. For example, laminectomy is highly invasive. There's destruction of muscle and bone and ligament in your spine. When the surgeon removes the bones and ligaments out of your spine, it creates tremendous amount of scar tissue and instability of the spine. Patients frequently come back needing spinal fusion. Patients with laminectomy are often in chronic back pain for the rest of their life, going in and out of pain management, on and off of pain pills, and in and out of physical therapy. They frequently require multiple surgeries in order to feel some type of pain relief. An alternative treatment is called a microdiscectomy. Microdiscectomy is another invasive procedure where the surgeon is removing bones and ligaments to get down to a herniated disc that's pinching a nerve root. Microdiscectomy is not a treatment for back pain. It is only recommended for leg weakness, leg numbness, and leg pain. Microdiscectomy does not fix back pain and should be avoided if you have back pain. Laminectomy does not fix back pain and should be avoided if you have back pain. Spinal fusion is a treatment for back pain. The surgeon must either remove or fuse the disc using hardware such as screws, rods, and bone graft, including cadaver bone graft. You're receiving biological bone graft from a dead person. That's what's allowing your bones to fuse together. Now, these spinal fusions can be quite effective at eliminating discogenic back pain, which is the type of back pain that you have. However, they carry a very high risk of complications. Complications such as blood clots in your legs, which could migrate to your lung and kill you in a process called pulmonary embolism. They also have a high risk of infection. Every patient that does a fusion requires post-operative narcotic opioid pain medication. Opioids are known to be dangerous, addictive, and have a high potential for abuse. You don't want to start opioid painkillers if you can avoid it. With the Duke laser disc repair procedure that we have recommended for you, there is no need for post-operative opioids. Our patients are treated with a small 7mm incision. That incision has minimal to no bleeding, and it heals within a few days. There is no need for narcotic painkillers. If you have the Duke laser disc repair, we can fix the back pain within 3 days coming from your damaged disc. We recommend you talk to our schedulers. They'll answer any additional questions you have. We'd love to see you here at Duke Spine Institute and provide you with the highest quality, most advanced treatment in the world that gives you the safest, most effective outcome in the world that lasts a lifetime. Thank you for listening. Welcome back. Because I'm bored. Okay? Because I'm bored. My staff asks me why I do what I do. Folks, I want to reiterate, this patient had the disc seal procedure. Henry and I are going to do a little talk on the disc seal, because it's not often in life you get to look inside a disc that's had the disc seal. But we do that at Duke Spine all the time, because our patients that have the disc seal and it doesn't work, it's never worked on any of the patients we've seen. And now we're going to show you guys what the inside of a disc that's been treated with disc seal looks like. And this is it. Look at this thing. It looks like it's gone through Armageddon. Okay? If a disc ever saw Armageddon, it would be these disc seal discs. Because that chemical they're injecting inside your disc just chews up the disc. Look at this. All scar tissue and hemorrhaging. It looks like absolute what I call a dog's breakfast. All right. Of course, nowadays with farmer's dog's breakfast don't look that bad anymore. But back in the 80s, the dog's breakfast never looked good. But the dogs loved it. Thank you, Dr. Burness. So this disc is completely messed up from that disc seal, but we're repairing it by cleaning out all the garbage they injected into the disc that never took away this patient's pain. He's had pain for 40 years. We're going to get to meet him tomorrow, I think, with one of our testimonials. I've got about a minute left on this disc, and then we're going to end the stream, and I'm going to bring you guys back for the bilateral SI joint DPR he's going to have done, and his facet treatment, L5-S1. Any questions?
Yes, we have a question coming from Janet on Facebook.
Hi, Janet on Facebook. Welcome.
Saying, with all the changes happening with the HHS department, do you think the spine scams will be exposed? Maybe you can finally be able to have your way finally taught in medical schools.
Well, I would love for that truth to come out. I don't believe it is, for two reasons. Number one, remember, it's us against everybody else. The hospitals want to keep things status quo. They make the most money from spine surgeries, invasive spine surgery. The surgeons want to keep things status quo because they make the most money from invasive spine surgeries. The pain management doctors want to keep things status quo because they're making more money today than they've ever made in their history. They used to make $200,000 a year. Now they're making millions doing all these pain treatments like disc seal that don't work, okay? And stem cells and PRP and all that treatment that doesn't work on the spine. And then you've got the implant companies, the companies that manufacture and sell these things like disc seal juice and whatever, metal plates, screws, cages. Those companies are making billions profit. So you got hospitals, surgeons, pain management doctors, and implant companies, all those companies making billions of dollars, and the insurance companies are loving it because none of that stuff works. They know it, the patients know it, and for the most part, the patients refuse those treatments and don't get them done. So the insurance companies get to save that money of the patients that don't get treatment. You understand? And I'm up against all of that. And they are very smart people and very aggressive. And they're not going to let little old Dr. Duke Machen get in the way of their profits. They don't care how many people they got to hurt. Patients represent an investment. That's it. A way for them to get their money. They can't get their money without you. And as long as people are willing to lay down and get disc seal procedure done, lay down and get fusion done, lay down and get stimulators done on their bodies, as long as people are willing to keep letting these doctors and hospitals do treatments that don't work, as long as the public is willing, then nothing will ever change. What has to happen is people have to say enough is enough. We want our health back. We want doctors to do what's best for us and not what's best for them. And when that happens, that's when change will occur at HHS and not before then. Donald Trump doesn't even know I exist. Neither does anybody that works closely with him. Those guys that he picked, Robert Kennedy and who's the doctor? Pinsky? Is it Pinsky or who was it? No, it's that other guy. What's his name? That Dr. Oz guy? Those guys are a joke. I mean, I like the fact that that Kennedy wants to make America healthy again. He's got his heart in the right place. It's just he doesn't have the training and knowledge. He has zero training. He doesn't know how to do it. He wants to do it. He's given up on the doctors that had the training. He doesn't trust them, and neither should you. But he doesn't know how to fix the system. I do. I know how to fix the system. He doesn't know it. But nobody's coming to talk to me. Nobody. I mean nobody. They don't even know I exist. Because I'm not connected. I'm not political. I'm not with the Mayo Clinic. I'm not with Harvard or Hopkins or Columbia or any of the big companies. They hope to God I die of a heart attack next week and I disappear. And everything I do disappears with me. But that's the worst thing that can happen for the American public and the world, is for my work to go unrecognized and forgotten about. It will be a travesty. All right, we're done with this disc. I'm just telling you, look at that. For those of you who have been coming here for a long time watching my surgery, this thing looks terrible, right? It doesn't look like a disc normally looks, but that's because some doctor stuck a needle in here and injected junk that made it look like this, okay? All this dead tissue, this scar tissue, all of this created by the disc seal procedure. Very bad. And the patient stayed in pain. He paid out of pocket for it, by the way. Never made him any better. Okay? Too many scams out there, folks. Too many. All right, we're going to finish this and move on to his SI joints. Henry?
Yes, sir.
Any other questions before we depart?
No current questions.
All right, join us for our next procedure, bilateral sacroiliac joint, Duke plasma rhizotomy.